Okay, pathophysiology of diabetes mellitus. So diabetes mellitus, there are basically two different types, and we've called them different things over the years. The current preference is to call them simply type 1 with the number 1 and type 2 diabetes. Now type 1 diabetes used to be called insulin dependent diabetes, and type 2 diabetes used to be called non-insulin dependent diabetes, but we have figured out that this is not really a good way of defining them because many type 2 diabetics go on to become insulin dependent. So anyways, we're left with these two types. So basically we have the pancreas here. Just a little review of what we just talked about with the endocrine pancreas. And the endocrine pancreas is filled with these, little islets of Langerhans. And inside the islets of Langerhans are beta cells. And the beta cells crank out insulin in response to glucose that is ingested. So we have a guy here eating a Twix bar and ingesting lots of glucose, and the glucose is going down, making its way down into the pancreas, and when the pancreas detects a high level of glucose, it cranks out insulin, and insulin goes into the bloodstream and goes to various organs and does its thing. Now, so does its thing. We'll have it say here's the liver, here's a liver cell. The liver cell has a little insulin receptor. The insulin binds with it, and remember what the cell does. That increases the glucose transporter, so glucose is taken up by the cell, and we get lots of glucose in the cell, right? From this guy's Twix bar. Okay, so what happens, what goes wrong with that picture? Well, with type 1 diabetes, the problem is something happens to that causes destruction of the beta cells inside the islets of Langerhans. And what happens, why does this happen? Well, it seems to be an autoimmune response that progresses fairly quickly. It seems to be related, it seems to be caused by molecular mimicry, where there are viruses, and it's sort of been connected to, there's been a suggested link between measles and mumps. It's interesting though, because even though we have vaccines for measles and mumps and they're not common anymore, we still see a lot of type 1 diabetes, and it didn't seem to decrease the amount. So, or it could be a different virus. But anyways, the theory is that the virus, here I'm going to draw a little capsid of a virus, has proteins on it that look very much like proteins that are on the beta cells in the pancreas. And what happens is, the immune system begins to, here, let me draw a different color here. The immune system begins to create antibodies to these proteins, and it destroys the virus, but it also goes on to attack and destroy the beta cells in the pancreas. So that is one theory. There's another theory that that there could be connections with very early exposure to cow's milk. So similarly, in cow's milk there may be a protein or a peptide that looks very much like a protein or a peptide that is on the beta cells in the pancreas. But in any case, whatever the cause, the immune system attacks the beta cells in the pancreas and one by one destroys them over a period of weeks to months, and then the patient will then lose all of his or her insulin producing capacity. So type 1 diabetes is defined by loss of insulin production. So, and usually it's relatively absolute. Most type 1 diabetics have absolutely no insulin production. They've lost all of their beta cells. Now, there can be other causes of type 1 diabetes. There are some people who have severe and recurrent pancreatitis. This can happen with alcoholics. People who drink very heavily on a regular basis can develop pancreatitis. Also, people that have genetic conditions that predispose them to very, very significant hypertriglyceridemia can develop recurrent bouts of pancreatitis, and these bouts of just inflammation of the pancreas over time can cause destruction of the beta cells as well. And then obviously, if you have a patient that has a pancreatic mass and needs to have the entire pancreas removed, they will be de facto, they will become a type 1 diabetic because they've had their pancreas taken out and no longer have insulin production. Okay, so type 2 diabetes is actually not a disease of loss of insulin production. It's actually a disease of insulin resistance. And I think we're starting to understand this disease a lot better, but we still don't understand it completely, what causes insulin resistance. So with type 2 diabetes, the islets of Langerhans are just fine, and the beta cells are just fine. So what happens is, we have these happy little islets of Langerhans with lots of happy little beta cells in them that are perfectly capable of producing all the insulin that we need. The dysfunction here is actually in the cells that are receiving the message from the insulin. Now remember what happens here, inside the cell. Take us down to the cell here. Remember, on the cell membrane, we've got our insulin receptor, and we've got insulin binding with it here. And that sends out second messages, to the glucose transporter and to the sodium-potassium pump and to various other places within the cell. And what happens is, and we don't know exactly how this happens, but the current theory is that people who have high levels of circulating fatty acids in their blood, hypertriglyceridemia, hypercholesterolemia, this could come from partially from inheritance and partially just from eating a diet high in fat, or high in high in a combination of fats and carbohydrates. This causes a high level of certain inflammatory cytokines and hormones within the blood, and it's these processes that are thought to interfere with or block this second messenger system. So the insulin is binding with the insulin receptor, but the message can't go any further beyond that because of the processes that are occurring from the inflammation due to high levels of circulating fatty acids. So what happens here is you end up with a situation where we have glucose that can't get into the cell. So we end up with a very high blood glucose level. And what does a high blood glucose level do? Well, it stimulates the beta cells to produce more insulin. So they produce more insulin, and eventually we get enough insulin that the cell is at some point convinced, at some point it can overwhelm this blockage here because we just have enough insulin stimulating enough receptors. But as the problem progresses over time, we get high levels of glucose cranking up these beta cells, and what happens is these beta cells for a while function just fine and crank out all the insulin that the body needs. So we have high levels. Really, we have what's called hyperinsulinemia. Now, with hyperinsulinemia, we don't have a diabetic yet. It's really a pre-diabetic. The patient is compensating just fine, right? So if you tested this person's blood glucose level, random check, it would be normal. Early on in the disease, if you checked a glucose load, it would still be normal because the beta cells are able to compensate by cranking out extra insulin. But what happens is after years and years, literally, of these beta cells working overtime to produce extra insulin to overcome this blockage in the system, they begin to burn out. And that is when we start to decompensate. We start to lose some of these cells. And then, as our insulin levels drop back to normal, we can no longer compensate. And then our blood glucose levels start to get way above normal. And then it's detectable diabetes. Now, the problem is this will continue to get worse and worse and worse unless we correct the underlying problem, which is metabolic syndrome. We need to lose weight and change our lifestyle, right? If we don't lose weight and change our lifestyle, we're still going to be interfering with the second messenger system that is the underlying cause for type 2 diabetes, and the disease will continue to progress. We'll continue to have higher and higher levels of glucose. That will continue to put pressure on the beta cells, and eventually all of the beta cells will die off, and you'll have a type 2 diabetic who has now become insulin dependent. And that's why you see these patients over time. First they start off on they might be able to be diet controlled to begin with. Then we'll add metformin because their BGs are creeping up, and that might work for a year or two. Then we'll have to add a second oral agent that might hold us off for another year or two, and then eventually we're going to have to add insulin in order to control the blood glucose, because we haven't done anything to treat the underlying condition, which is the inflammation that's causing damage to the second messenger system. Okay, so what are the complications that can be caused by diabetes? Well, with type 1 diabetics, one of the acute complications that we worry about is diabetic ketoacidosis, or DKA. Now, this is an acute problem that is caused by patients that do not have the insulin that they need to get their cells the glucose that they need to survive. So this can happen for two reasons. One is an increase in glucose demand, and usually this is due to stress. I see it most commonly with infection. So you get a patient with pneumonia, a bad UTI or whatever, and that increases their cells' need for glucose, and it can, even if they're taking their normal levels of insulin, it can tip them into DKA, and I've seen this, dozens of times. The other thing that can cause DKA, and this is fairly common as well, is patients stop taking their glucose, stop taking their insulin. So decreased insulin administration. This happens to a lot of, I see a lot of teenagers or young people in their 20s that I think they have the mortality complex or immortality complex, in which they, nothing will hurt them, so they just stop taking their insulin, and then within a day or two they go into DKA. So what happens is, without insulin, our cells can't, if we don't have insulin, then our glucose transporters can't let glucose in. So the glucose is, we have plenty of glucose in the bloodstream, but it can't get into the cells, right? So if it can't get into the cells, two things happen. One thing is the glucose outside of the cell becomes very, very high, so we have elevated BGs. And then the other thing is there's no glucose in the cells, so the cells have to shift to other substrates for energy production. In particular, they have to shift to using proteins, and lipids. Now when they do that, our bodies can work fine with just proteins and lipids, but when we use a lot of proteins and lipids in our body, one of the byproducts of metabolism of proteins and lipids is ketone bodies, or keto acid. So ketoacidosis is actually due in part to the development of high levels of these ketone bodies, and this will cause an increase in hydrogen ion concentration, which actually I should just write it like this: it actually decreases pH, because pH is actually a negative log scale of hydrogen concentration. So a decrease in pH actually means an increase in hydrogen ion concentration, so it becomes more acidic. So one of the other effects that I wanted to talk about as well is, remember that insulin is a regulator of the sodium-potassium pump. So without insulin, we are not pumping as much sodium-potassium into and out of the cell. Now this is interesting what happens with potassium, because potassium is not pumped inside the cell, so what we end up with is intracellular hypokalemia. So it drops down to below its normal intracellular levels of about 140 milliequivalents down to maybe 110 milliequivalents. So if you add that up throughout all the body's cells, we lose a lot of potassium from our cells. But potassium in the bloodstream is very closely regulated by the kidneys. So once our potassium gets above like 4.5 to 5, our kidneys just produce urine with more potassium and pee it out. So what happens is, we have normal potassium levels in our plasma, but our entire body has become very hypokalemic because of all the K lost from the cells. So it's interesting, because what happens, and this doesn't cause too much of a problem until we go and fix the situation by giving the patient insulin. So those of you who work in the ICU know that even with a normal potassium, oftentimes we will order to administer potassium before we start the insulin, because we know that it's going to drop significantly, because we're going to start out with a normal level of potassium here. We're going to give insulin, turn on these sodium-potassium pumps, and we're going to begin to restore this potassium level to normal within the cell, and it's going to do that at the expense of potassium outside the cell. So we're very quickly, within hours, drop from 4.5 to 2. So we need to, good nurses anticipate this, and we'll make sure that we watch the potassium level very closely, and we administer it even before giving the insulin. Okay, so what are the other effects? One of the effects of ketoacidosis is mental status changes, and this actually happens with ketoacidosis and another condition called non-ketotic hyperosmolar coma. And this is primarily due to increased glucose levels, increasing the osmolarity of our blood. We have so much glucose going around, and I've seen people with glucoses up in the 900s. And this actually causes electrolyte shifts in our central nervous system and causes mental status changes. Also, oftentimes you'll see people with abdominal pain, and this we believe is caused by the decreased pH, and it causes sort of a partial ileus. Okay. The next thing I wanted to talk about are the long-term effects, long-term complications. And the major long-term complications from diabetes are primarily due to the effects of chronic hyperglycemia on the endothelial cells. So, throughout our body, in all of our blood vessels, we have, they are all lined with these endothelial cells. And what happens with diabetes is that the hyperglycemia is actually directly toxic to these cells. And also, remember, glucose is responsible for the transport of all substrates into the cell. So we also end up with, along with hyperglycemia, we also end up with hypertriglyceridemia and cholesterolemia, because the cells cannot take up cholesterol, triglycerides, and other fatty acids into the cells. So the hyperglycemia causes injury to the cell, and that causes inflammation. And this inflammation, and we're going to get into the nitty-gritty details of atherosclerosis a little bit later, but this inflammation starts a process of a cascade that occurs that causes atheromas to begin to form, which is a combination of inflammatory cytokines with the introduction of cholesterol into the basement membrane underneath the endothelial cells. Now, this is occurring throughout the vascular system. In the large arteries, the aorta, the femoral arteries, the renal arteries, the hepatic arteries, the mesenteric arteries that are feeding the gut, actually the stomach and the gut. So what can this cause? All sorts of problems. It can cause aortic aneurysms to form. It can cause atheromas to form in the renal arteries, causing renal artery stenosis, which can increase blood pressure. It's a secondary cause of hypertension. It can cause atheromas to form in the arteries that feed the stomach and the gut, which can cause gastroparesis and mesenteric ischemia. It can clot off the femoral veins, or the more distal peripheral veins, and cause peripheral artery disease. And then it can also affect the little microvessels, little tiny vessels, like the vessels that are feeding the eye. So it can cause retinopathy. Oh yes, and I can't forget the heart. Of course, it can cause coronary artery disease as well by causing plaques within the coronary arteries. So it's the same process throughout the body in large arteries and small arterioles that are causing all the macrovascular disease, coronary artery disease, aortic disease, renal artery stenosis, mesenteric artery disease, and also microvascular disease, which can cause retinopathy, and it can also do further damage to the kidneys through microvascular disease. It does damage directly to the glomerulus, which is the intersection between the small renal arterioles and the Bowman's capsule. So now that we understand this disease better, we know that if we control VGs, we can slow. Yeah, hold on, please.